Welcome to the narrated presentation titled Communicating Infectious Concerns with Antibiotic Prescribers. This presentation will discuss techniques to improve communication between members of the healthcare team and specifically help to address discussing infection concerns with providers. Communication is the lifeline of a well-functioning team and serves as a coordinating mechanism for teamwork. Effective communication skills are vital for resident safety and are an important component of antibiotic stewardship interventions. First, we will describe the components of the SBAR tool and when to use it. SBAR stands for Situation, Background, Assessment, and Recommendation. Next, we will walk through some of the cases that use SBAR to improve the communication between providers and nursing staff. Finally, we will show how the SBAR tool can support the role of nurses as advocates for antibiotic stewardship. Failure to communicate effectively as a team significantly increases the risk of error. A 2004 Joint Commission analysis showed that communication failure was the root cause of over 70% of sentinel events. Unfortunately, over 75% of patients involved in those sentinel events died. In a recent survey of 2,000 healthcare professionals, intimidation was found to be the root cause of medication error. Half of the respondents in that study reported feeling pressure to give a medication for which they questioned its safety, but could not effectively communicate concerns. This comes up a lot in antibiotic stewardship interventions. Learning how to improve communication and alleviate this feeling of intimidation can reduce unnecessary prescriptions or medication errors. In long-term care, there are many barriers to communication. Recent surveys show healthcare providers in this setting report a lack of physician openness to communication, various logistical challenges, including noise, or a lack of a team room or private location to discuss resident issues. Some cite inconsistencies in nurse preparedness, often due to high staff turnover. There are many challenges to effective communication: overwhelming workload, rotation of care due to shift changes, varying communication styles, or personality differences. While sometimes it is difficult to overcome these challenges, it is helpful to remember a few points to improve communication, even in challenging situations. Effective communication should be complete. Try to communicate all relevant information while avoiding unnecessary details. Clear. Use standard terminology and make sure the whole team understands. Brief. Being concise is key, especially with heavy workloads and time distractions. Finally, it should be timely. Communication should be provided in regular updates to family members and providers regarding status changes of the resident. Try to avoid delays that could compromise a resident's condition, even if you are caught up in another activity. SBAR stands for Situation, Background, Assessment, and Recommendation. SBAR is a framework that helps to guide communication between medical professionals. We talked about this tool previously in the CUSP module about improving teamwork and communication. It is a communication style that was developed in the military. The purpose is to communicate in an organized style familiar to both the speaker and the listener. Using this method helps to present objective information and a complete clinical impression to the provider. This, in turn, should help the provider develop an informed response regarding changes in patient status. Let's walk through the steps. First, situation. State who you are calling about and why. Provide a 5 to 10 second punchline. Next, background. State briefly what you know about the history and the current status. Include objective data, recent vital signs, pertinent exam findings, and notable labs. Next, assessment. Here, state what you think the problem is and how severe it is. A diagnosis is not necessary, but a specific concern should be stated in the assessment. Finally, recommendation. State what you think needs to happen for the patient and also suggest a time frame. 87.5% of nurses who utilized the SBAR tool in a recent study reported that they found it useful for organizing and communicating information to medical providers. They reported that SBAR helps them to organize thinking and feel more confident in communication. Let's try and put our SBAR skills to use with a case. Elma Randall is a 92-year-old long-term care resident with a history of a pulmonary embolism. She is on warfarin. Overnight, she got up and tried to reach the bathroom, but she tripped on the railing of her bed and fell on her hip. When nursing found her, she was confused. She did not think she'd hit her head. She asked to just go back to bed. After the nurse helped Elma get back into bed, she called the on-call provider to notify him of the event. He called back about 3 hours later because he was sleeping and couldn't hear his phone. Here is how the initial conversation goes. We'll call this take 1. Nurse: Hello, Dr. Khan. I'm calling about Elma, a 92-year-old long-term care resident here. I just wanted to let you know she got up and fell out of bed tonight. She seemed confused, but we were able to get her back into bed. She's sleeping now. Dr. Khan: She's confused? Maybe she has an infection. Let's get a urinalysis and urine culture. You can also get some imaging of her head in the morning if she still seems out of it. Nurse: Okay, thank you. I will do that. The nurse hangs up the phone, but she still feels uneasy. Why didn't Dr. Khan want the resident to go to the hospital to get checked out? The resident wasn't complaining of any urinary symptoms, so it didn't seem right to look for a urinary tract infection. But he sounded tired and distracted when he answered the phone, so she didn't want to alarm him. Let's think through this communication and talk about what we may have missed. Overall, was this communication effective? No, it was not. The provider did not get all of the information, and this could have a significant effect on the resident's outcome. Was the communication complete? No, the nurse did not provide information about the resident's anticoagulation status, which is an important point to share, especially in the setting of a fall. She didn't give any updates about the resident's vital signs, physical exam, or other symptoms that may have helped to determine if the fall was secondary to an underlying infection. Was the communication clear? No. Even though so much information was missing, the prescriber did not ask any questions at all. He should have at least asked about urinary symptoms before sending a urine culture. He should have also asked for basic information following a fall, such as whether she hit her head, what part of her body did she land on, and if she is on anticoagulation medications. Was the communication brief? Yes, a bit too brief in this instance. Was the communication timely? No, despite the nurse's prompt attempt at notification, the provider did not respond to the initial call, so there was a prolonged time interval before the communication occurred. Let's walk through this again, applying SBAR principles to help guide the discussion. Situation: Hello, Dr. Khan. I'm calling about Elma Randall, the 92-year-old resident in room 332. She tripped and fell this evening and landed on her hip. She seems okay, but slightly confused. Background: She has a history of pulmonary embolism, is on warfarin, and has mild dementia. Before she fell, she was oriented to person and place and at her baseline mental status. Now she seems a little confused, but she is otherwise alert and responsive without any significant mental status changes. Her vitals are normal, and she did not complain of any symptoms other than pain in her hip. Assessment: I am concerned because of her anticoagulation status. She is already developing a large hematoma on her hip. Recommendation: I think she needs to be transferred to the hospital to have some imaging to confirm there is no bleed or fracture. Remember take 1 of this call? The nurse hung up the phone feeling uncomfortable with the response she got from the provider. Getting a response is also an important component of the SBAR format. You should expect a response from the provider, and you may want to suggest the kind of response you would like. For example, the nurse could also have added, I think that Elma needs to be seen sooner rather than later, and I wouldn't feel comfortable waiting until morning. It is okay to give these recommendations. This type of communication sets up the provider to offer an effective and appropriate response. The provider may ask for more information or recommend a different course of action. Regardless, they should be able to make an informed decision. An appropriate response is more likely if initial communication is effective. As we saw from the previous example, your assessment of the situation can greatly influence the provider's response and significantly change the care of the resident, including their outcomes. Consider the following case. The microbiology lab must notify the facility whenever a patient has a culture growing a multi-drug resistant organism. The reason is so that the resident can be placed on contact precautions to prevent the spread of resistant organisms to other residents. You get a call saying one of the residents you are caring for is growing a multi-drug resistant organism in his urine. The resident is not on antibiotics and is feeling fine. His urine was sent over a week ago, but no one on the floor can recall why. It is Saturday at 8 p.m. You call the provider to relay the information from the microbiology lab. This is the nurse for Mr. Bollinger in room 214. The lab just called me, and he has a resistant organism growing in his urine culture. Based on what the nurse relayed to the provider, how would you expect him to respond? Come in on the weekend and evaluate the resident. This is possible but unlikely, and probably not necessary at this point as the resident is feeling fine. If urgent evaluation was necessary and the resident was sick, this information would need to be clearly portrayed to the provider. Start an antibiotic. Likely, you would be surprised how often this happens. If the appropriate information regarding symptoms in resident status is not portrayed, the provider can often assume the resident is sick and start them on antibiotics based on lab results, even if it isn't clinically necessary. Tell the nurse to wait until Monday and notify the regular provider. I'm too busy right now. This also happens, and while it is probably reasonable to wait until Monday in this situation, telling the nurse they can't be bothered is never an effective means of communication. Ask for more information regarding symptoms. This would be the ideal response, as more information is critical to make appropriate decisions in this situation. Unfortunately, this may be unlikely unless the nurse sets the provider up to ask more questions. In general, when a provider receives a page, they assume there is a clinical reason for the call. Without context, a call about a positive urine culture will likely lead to an antibiotic prescription. The fact that a nurse has to call to inform someone about the result of a laboratory test because of a policy is not obvious to most providers. One example of how to frame the communication is to state, I'm calling because our policy states that I must inform a provider about all positive cultures. Knowing this makes it much easier for a nurse to frame the communication so that the provider understands the call is not about clinical concerns, but is driven by a result sent from the laboratory. Let's try that call again using our SBAR format. Situation. Hello, I'm calling about Mr. Bollinger in room 214. The lab just called to notify me that he has a resistant organism in his urine. I'm calling because our policy states that I must inform a provider about all positive cultures. Background. He's an 83-year-old man with Parkinson's disease in our long-term care unit. He has no catheter. He's not on antibiotics, and no one can recall why the urine culture was sent. Assessment. He has no signs or symptoms of a urinary tract infection. His vital signs are stable, and he is clinically at his baseline. Recommendation. I think we should continue to carefully observe him. I placed him on isolation precautions. I don't see a need to start him on antibiotics at this time. While Take 1 could allow for any of the previous responses by the provider, Take 2 provides information in a clear and concise manner. Consider the previous possible responses the provider may take based on Take 2's communication. Come in on the weekend and evaluate the resident. Unlikely, as the nurse reassured him this was not necessary. Start an antibiotic based on the urine culture results. Also unlikely. The clear communication and recommendations by the nurse suggest there is no need to start antibiotics, and the resident will likely be spared unnecessary exposure to antibiotics and potentially harmful side effects. Tells the nurse to wait until Monday and notify the regular provider. I'm too busy right now. Hopefully the provider will be motivated to interact with more effective communication based on what they received, rather than saying they can't be bothered. Ask for more information regarding symptoms. The nurse did a great job providing a thorough assessment of the resident. The provider may still have some questions, which is good. It means that the SBAR framework laid a strong foundation for effective, respectful communication. The most likely response by the provider after take 2 would probably sound more like this. Sounds good. Thanks for the update. Let's discuss a final case. Mark Padillo is a 75-year-old man with dementia and progressive multiple sclerosis. He has a chronic indwelling urinary catheter for neurogenic bladder. On Saturday, he had 2 temperatures of 99 degrees Fahrenheit and seemed more subdued. Mark felt like he had more pain than usual, but is vague about where that pain is coming from. The nurse reached the on-call provider and communicated her impression via SBAR. Together, she and the on-call provider decided on a plan of active monitoring to include vital signs every 4 hours, oral hydration, and acetaminophen for analgesia. On Sunday, Mark still had a temperature of 99 degrees. The on-call provider ordered blood work, a chest x-ray, and placement of a new urinary catheter, and then to get a urinalysis and urine culture. He also decided to start Mark on oral antibiotics, choosing a 10-day course of amoxicillin clavulanic acid. On Monday morning, the reading on the chest x-ray is back, and it is unchanged from his chest x-ray 2 months prior. The nurse calls Mark's usual provider to let her know about the read. The nurse also tells her that Mark has improved and seems back to his baseline behavior and temperature. He is now on day 2 of amoxicillin clavulanic acid. On Wednesday, Mark's urine culture results come back as negative or no growth. His nurse sees this and reviews Mark's recent CBC and urinalysis results. The CBC indicated a white blood cell count of 9.2 thousand, and the urinalysis showed 67 white blood cells per high-powered field. She also notes that Mark has been at his baseline since Monday. The nurse faxes the urine culture results to the provider's office. The provider sees them at the end of the day, about 5 minutes before heading home for the evening. Mark receives another 6 days of amoxicillin clavulanic acid. Around day 8, he develops diarrhea. The stool is sent to the laboratory to evaluate for C. difficile infection. Those results come back negative 4 days later, and he is finally allowed out of isolation. He has finished his complete course of 10 days of antibiotics. The nurse has kept the provider informed, but did not set up the provider to think about stopping antibiotics. How the nurse communicates Mark's status to the provider can make a big difference in Mark's care. Faxing the negative urine culture results did not set the provider up to think about stopping antibiotics. Using SBAR over the phone or by fax would likely lead to a different result. Here's an example of a written SBAR. Situation: Mark Padillo, 75-year-old with multiple sclerosis. Background: had a fever to 99 degrees Fahrenheit over weekend. Started amoxicillin clavulanic Sunday. Assessment: urinalysis was 67 white blood cells per high-powered field. He has a chronic indwelling urinary catheter. His urine culture came back negative. Also, his white blood cell count was normal. And you may remember his chest x-ray is unchanged from his baseline. No fever since Sunday evening, back to baseline on Monday. Recommendation: he seems to be better. His labs are normal except for the white blood cells in his urine, which he usually has. Should we consider stopping the antibiotics? Today is day 4 of a 10-day course. The provider agrees to stop the antibiotics and check up on Mark during her rounds on Friday morning. She thanks the nurse for helping remind her about the antibiotics, and she is glad they decided to stop them. We have now completed the narrated presentation, communicating infectious concerns with antibiotic prescribers. Some key points included: 1. Effective communication is a key component to ensure resident safety. 2. SBAR provides the framework for clear, concise communication about a resident's status. 3. Your assessment and impression of the resident is a critical part of the communication and directly affects provider responses and resident outcomes. Thank you all for your attention. Feel free to review the entire presentation as many times as needed. The findings and recommendations in this narrated presentation are those of the authors, who are responsible for its content, and do not necessarily represent the views of AHRQ. No statement in this narrated presentation should be construed as an official position of AHRQ or of the U.S. Department of Health and Human Services. Any practice described in this narrated presentation must be applied by healthcare practitioners in accordance with professional judgment and standards of care in regard to the unique circumstances that may apply in each situation they encounter. These practices are offered as helpful options for consideration by healthcare practitioners, not as guidelines.